Okay, well, good afternoon, good evening, everyone. Thank you very much for your attention. Sorry, there's a few technical difficulties with the new webinar platform, but I hope that this should be slicker as we go along. Very grateful today to have Dr. Alison Winstanley, who's a hepatobiliary and GI pathologist working at University College London. She's been a strong supporter of teaching for the Pathological Society and also on this course before. So very grateful for her time today. She's going to be talking on hepatocellular tumours. I don't want to take any more of her time because we've already eaten into it, setting things up because it's a bit, but now we know what we're doing for next week. So without further ado, I'll pass over to yourself, Ali. Thank you very much.
Thank you very much, Richard. Right, welcome everyone. So yes, as Richard said, I'm from University College London. Here is the building and today it is snowing here. So I think if you ask anyone who I've taught over the last 30 years, they will say that I'm not known to overcomplicate things. And this is my kind of what's in my brain, my toolbox. And I must say that initially when you start off, when you're going to approach a case, be it a medical liver or a resection case, the real important thing is context. And you get the context by getting a good clinical history and knowing what the radiology shows. So clinical history, important factors are things like sex, age, medical history, medication history, including oral contraceptive, androgen use, syndromes such as metabolic syndrome. So there's a lot of important factors that you can get just from the clinical history. On radiology, you want to know what size the lesion is, if there's any background chronic liver disease, if there are multiple lesions, the character of the lesion, so if it's hypervascular, if it's fatty, if there's washout. And they're important factors you can get before you even pick up the specimen. When you get a resection specimen, you're going to the macroscopy, becomes very important, and you need to have seen the specimen that you're working on. Again, it's similar things to radiology. How big is the lesion? What's it associated with? Is there any evidence of background chronic liver disease? Then we come to the processing of the specimen, and you're getting these slides. And again, morphology is crucial. I think when I first started as a registrar, we probably just had morphology and reticulin stain, and pretty much apart from one or two, all the other stains have come in since then. So morphology and reticulin staining are very important stains. Additionally, now we have glutamine synthetase. This is useful in medical livers as well as lesional livers. In medical livers, it's very good with vascular conditions to identify the central venular areas. And in lesional livers, we will see how we can use the stain. You have the differential stains for the hepatocellular adenomas, CRP, C-reactive protein, serum amyloid A, liver fatty acid binding protein, and beta-catenin. And we'll see how those can be applied. There's other stains that can be used where you know you've got an hepatocellular lesion, but you're not sure if it's malignant or not. And this can be, here you can use stains such as glypican-3, CD34, and heat shock protein 70 can help. You may have cases where you're not sure if it's actually an hepatocellular lesion you're dealing with. And to say that it is, you need something such as arginase or HepAL1 HSA. Other stains including CD10, polyclonal CEA, CD13, and some centres around here also have bile pump excreted protein staining, and they show a specific canalicular pattern of staining. And then there are other stains that you may use when working up a liver lesion, and these would include HMB45 for angiomyolipomas, metastatic melanoma, BUR-EP4 to prove that it's an epithelial tumour you're dealing with, and vascular markers such as ERG and CD34. So looking at some of these stains in normal liver, because obviously if you're going to use them, you need to know what it's going to look like. So glutamine synthetase here on the left has a classically perivenular pattern of staining in a normal liver. C-reactive protein and serum amyloid A both stain very similarly, and they have either a negative or have this faint blush of staining. Liver fatty acid binding protein is normal in background liver. Beta-catenin should show nice, crisp, membranous staining, but no nuclear staining. CD34 tends to highlight sinusoidal areas around portal tracts, and glypican-3 is negative. So that's normal staining pattern in normal liver. So when you are approaching a liver lesion in a liver, the important thing is to see whether there's any background chronic liver disease, because the differential diagnosis changes quite considerably. So in a non-cirrhotic liver, you're looking at reactive lesions such as focal nodular hyperplasia, benign lesions, and malignant lesions, both hepatocellular, but also of bile ducts, of blood vessels, of lymphomas, and also metastatic spread. So the differential is extremely wide. When dealing with a cirrhotic liver, the differential becomes extremely small. Regenerative nodules aren't usually biopsied. You may get a dysplastic nodule, but normally it's lesions of over 2 centimeters that are worrying that will end up being biopsied. And these will be things such as hepatocellular carcinoma and cholangiocarcinoma. So I thought to highlight the use of all these stains, we'd have a look at a few cases and see how the immunostaining and the reticulin and the morphology changes between them. So this is case 1. This is a female of 46 who had 3 liver lesions on MRI. She was known to have a history of breast cancer, and they were worried whether she had metastatic breast cancer. This is a core biopsy. It's not the greatest. Here you have background liver, and here you can see this fatty or pale looking lesion. And this is the background liver at higher power. See the normal portal tracts. And when we look at the lesion, we see background steatosis, but these large, thick walled vessels. The lesional liver has these small unaccompanied arterioles, which are very important in targeted liver biopsies to know you're actually in a lesion. It can be very hard to identify. And more of these thick-walled, atypical arterioles with eccentrically placed lumen. So one side of the muscle wall is thicker than the other side. There's areas of ductular reaction. And the reticulin stain, the reticulin is preserved. The liver cell plates seem pretty much one cell thick, so there's no loss of reticulin here. And this is the glutamine synthetase staining, and this shows a map-like pattern of staining. So diagnosis. You're welcome to put it in the chat if you want to be interactive, but you don't feel you have to. But if anyone has any ideas, please feel free to put them in. But this isn't a test, and I'll happily tell you the answer. So this is focal nodular hyperplasia. So the glutamine synthetase in this case is very useful. In focal nodular hyperplasia, it classically has a map-like pattern of staining. Compared with the background liver that we saw previously. This is a resection, so you can see it a bit more clearly, but you have normal perivenular staining in background normal liver. In things like adenomas and hepatocellular carcinomas, the staining pattern can vary quite extensively. So it's important before you put a glutamine synthetase or use a glutamine synthetase test to have some idea of which lesion you're dealing with. So focal nodular hyperplasia, these are thought to be reactive lesions in response to abnormal blood flow. And you end up with these lobulated lesions with a central scar and the atypical vessels that I showed you earlier with eccentrically placed lumen. There's often a ductular proliferation. And sometimes in these you can get signs of colate stasis, and that will be Mallory material, copper-associated protein deposition. They can be multiple, and they're usually associated with other vascular malformations, so things like hemangiomas or other systemic vascular malformations, and can be associated with Klippel, Trenorni and von Recklinghausen syndromes, which also are cause vascular malformations. So moving on to case 2. This is a female, 49. She's known to have high-grade B-cell lymphoma, and they discovered a small lesion on the tip of her liver, and they're worried that she's got a deposit of lymphoma. So here's the lesion. Here's background normal liver. You can see you've got a portal tract here, and this is the lesion, this pale area. And when we look at the lesion cells themselves, you can see these unaccompanied arterioles, which, as I said, are very important to know you're actually in the lesion. And you have these pale monomorphic cells, no significant mitotic activity. When we look at the reticulin staining, again, the reticulin is preserved. The cell plates are no more than 1 cell thick. And when we do our special panel of staining, glutamine synthetase shows a vague centrovenular kind of patchy pattern. Liver fatty acid binding protein is negative. Staining for serum amyloid A is negative, and same with C-reactive protein. So I just saw someone did put in the chat about FNH, so well done. I'll just recap the features of normal liver, and it's really to show you what we're missing. And so this liver has unremarkable glutamine synthetase staining, negative serum amyloid A and C-reactive protein. Liver fatty acid binding protein is negative in this liver. So let's have a look again. And yes, liver fatty acid binding protein is negative. So this is a hepatocellular lesion, bland hepatocellular lesion. We're not worried about any malignancy, and it's lost liver fatty acid binding protein. Does anyone want to have a guess at what this might be? I think there's a bit of a lag, unfortunately. And here is the liver fatty acid binding, showing that area of normal liver that we saw before, and then negative. And well done, Sarah, with the HNF1 alpha inactivated adenoma. Yeah. So importantly, beta-casenin, with all adenomas, you have to be careful. With the beta-casenin, it can be normal livers, it stains membranous. If you get any nucleus staining, that's even 1 nucleus is significant. So you have to go over the stain very carefully to try and identify positive nuclei. And even in beta-casenin mutated adenomas, beta-casenin may be negative. So as said, the diagnosis is HNF1 alpha inactivated hepatocellular adenoma. And we'll move straight on to a second case. So this is now a 32-year-old female. She's known to drink alcohol excessively, and she's also on the oral contraceptive pill, so 2 risk factors. And she's got an incidental liver lesion. And this is this was a resection. You can see the background normal liver here, there's a vague demarcation. It's poorly defined, but goes along here with normal on this side and lesional liver here with these big dilated thin-walled vessels. Looks very hemorrhagic. There's some dark blue bits that look inflammatory. And when we look on higher power, you can see dilated sinusoidal spaces. These blue areas are standing out more clearly now. When we look at the blue areas more carefully, they're pseudo portal tracts. So pseudo portal tracts occur in this condition, and it's where you've got the inflammation, you've got an arterial, you have and a duct, a kind of ductular reaction, but you haven't got a main duct or a good going portal venule. You can see the background sinusoidal congestion. When we look at the reticulin stain, again, it's preserved. The cells are no more than 1 to 2 cells thick, and there is no loss of reticulin staining. When we look at the immunohistochemistry, it's kind of unhelpful glutamine synthetase patchy positivity, serum amyloid A and CRP positive. Beta-catenin just shows membranous positivity, but no nuclear positivity. And CD34 is patchy. There's no diffuse capillarization of the sinusoids. Does anyone want to make a diagnosis on this one? Yes, exactly. Thank you. This is an inflammatory adenoma. So hepatocellular adenomas, they're benign tumours of hepatocytes. They can produce bile, as can hepatocellular carcinomas. They, as I mentioned before, you look for these unaccompanied arterials to know you're actually in the lesion. And for those of you who see targeted liver biopsies routinely will know that some cases can be very subtle and very difficult to know you actually got the lesion. You can get a pseudoglandular or pseudoacinar pattern of growth, but it should be minimal and focal. Here is an HCC just to highlight pseudoglandular or pseudoacinar pattern of growth. And I find those quite worrying features. They do make me sit up and take a bit more notice. You shouldn't have any good going nuclear atypia. There shouldn't be any mitosis unless it's very hemorrhagic. And immunohistochemistry, as we've seen, is used for classification. This is just to highlight this importance of unaccompanied arterioles. So if you have a targeted liver biopsy and you're not sure where the lesion is, look for these unaccompanied medium-sized arterioles. Unaccompanied means that they don't have an associated bile duct. So normally, as in the lung with the bronchi, in the liver, the arteriole has accompanying bile duct, and they should go in pairs. So if you start seeing scattered unaccompanied arterioles throughout the lesion, you know you're actually in lesional tissue. And so unaccompanied arterioles, they may be atypical, in which case we're talking FNH, as we've already seen. If they're normal unaccompanied arterioles, you then need to know whether your reticulin's preserved or not. And then if it's preserved and there's no thickening of liver cell plates, you're looking at an adenoma. And if it is, then you're looking at, if there is loss, then you're looking at a probable HCC. Be careful if you see occasional portal tracts and something you think is lesional, because adenomas can encircle portal tracts and can be present, but they shouldn't be regularly spaced. Okay, hepatocellular adenomas are usually found in women, usually associated with the oral contraceptive pill. Worrying factors are tumours over 5 centimetres occurring in men, androgen related. Obviously, if they're beta-catenin mutated, they have a higher risk of transformation, malignant transformation. And the transformation rate is between 4 to 8%. It's probably nearer the 4%. And so this is the WHO 2020 classification, which has, I don't know if you guys have got it, but it has some fantastic tables in for adenoma differentiation and HCC. It's particularly good. This, I've just copied out the adenoma table. And I think we've covered most of this, but interestingly, when we were talking about putting things into context, knowing their clinical history, they do have relevant clinical history. So alpha-1 inactivated adenomas, you're looking at obese patients or patients with maturity onset diabetes of the young. you may have inflammatory adenomas can also be associated with obesity and metabolic syndrome and oral contraceptives. Sonic the Hedgehog activated HCA, we haven't covered, and I won't cover in this lecture as a case. I do have one, but it really comes down to molecular studies for definitive diagnosis of a sonic hedgehog activated HCA, and we don't usually do the molecular pathway. We usually go on morphology and the fact that it doesn't fit immunohistochemically with the other adenomas, and theirs is quite hemorrhagic. They're important because they have an increased risk of hemorrhage. And then we have the beta-catenin mutated adenomas. And of those, these two are the most important because they have an increased risk of HCC, transformation to HCC. They may express nuclear beta-catenin, but they may not. And so glutamine synthetase is used as a surrogate marker. And if you get diffuse strong expression of beta-catenin in an adenoma, that's a concerning feature, and these adenomas should be excised. Okay, case number 3. This is a male with a single 30mm lesion in the left lobe. And here we are, this is a large block, and you can see this lesion. It's kind of encapsulated, well demarcated, bit of a nodular background liver. For those of you who are doing exams, whenever, or in life, whenever you get a liver resection, your report should always comment on the background liver. There's no excuse. Okay, and here we have the lesion at one edge and then the background liver here. And when we look in the lesion, we've got a very fatty lesion. We've got hepatocyte ballooning, we've got cellular ballooning, we've got probable mammary material, and we've got bile. So we can pretty much make this diagnosis on the H&E and the reticulin stain. Once you've got bile, is only secreted by adenomas and HCCs, you know you're in a hepatocellular lesion. So then your only question is, well, is it benign or malignant? Here you've got quite prominent nucleoli, quite a lot of nuclear atypia. Here you can see these very big nucleoli, anisonucleosis. Here's these unaccompanied arterioles I was talking to you about. More unaccompanied arterioles. And a lot of fat. You've got more bile. Ballooned hepatocytes, lots of fat. Mitotic figure, more bile. So we've got mitoses, and when we look at the reticulin stain, we've got loss of reticulin. These cell plates are more than 4 or 5 cells thick. You can see it here. Okay, so we know we've got, because we've got bile, we know we've got an hepatocellular lesion. We've seen mitotic figures, they're concerning. We've seen nuclear atypia, also concerning. And we've now seen that this patient has reticulin loss within the lesion, which is concerning. So these all amount to, I'm going to give it away on tape. Anyway, it amounts to a diagnosis. The background liver is cirrhotic. We've got nodules of hepatocytes. We've got a mild chronic inflammatory infiltrates and background fat in the background liver. Here we have. Oh, sorry. Anyway, it's a well-differentiated hepatocellular carcinoma. This is a steatohepatitic variant, and the patient was known to have hepatitis C. I just didn't give you the information. In this country, hepatocellular carcinomas the most commonest underlying cause is obesity and alcohol. I understand in sub-Saharan Africa, the underlying etiologies differ, that you tend to have more hepatitis B, especially compounded by HIV co-infection, and also aflatoxin and secondary iron overload. So the etiologies are different worldwide. Oh, sorry, I didn't mean to ignore the chat. Someone's asked, how would you define atypical arterioles? So that would be, they're classical in, so these, when I'm talking about, when I'm talking about these ones, these are unaccompanied arterioles. They're normal arterioles, small, medium size, that you find in lesional liver. When I'm talking about atypical arterioles, I'm talking about the type of arterioles you find in focal nodular hyperplasia. And in that situation, these are really big muscularized arterioles, but instead of having an evenly spaced muscular layer around the outside of the vessel, it's eccentrically placed. So you'll have thickened wall one side and very thin wall the other side. And these are atypical arterioles you find in FNH. Please keep putting the questions in the chat. I'll try and answer them as I go through. So we know from just our H&E and our reticulin staining that this is an HCC. We don't really need any of the other stains, but if you did, you could use a Clipican, which you may be positive. Clipican's helpful if it's positive, it's not helpful if it's negative. You could look for the canalicular pattern of staining, such as here with the CD13 or CD10. You can also use polyclonal CEA and bile salt excretive pump staining. I don't use it, so I'm very bad at this terminology. You could use the CD34 and you'd probably get diffuse sinusoidal positivity. And if you wanted to know it's definitely liver, you could use an arginase or an HSA or HepAR1 to show that it's liver. But we don't need that in this case because we had all the information just on the H&E and the retic. And this is the canalicular pattern of staining I was telling you about. So the stain will stain in this kind of branching pattern. I always think it looks a bit like one of those balloon dogs. So just to recap, adenomas versus HCC. Adenomas, minimal nuclear atypia. You don't expect to find mitosis. If you do, sit up and take notice. And the reticulin is 1 to 2 cells thick, so it's preserved. In HCC, you have more nucleotypia, prominent nucleoli, anisonucleosis, mitotic figures, maybe even some necrosis, but not common. And the liver cell plates are thickened. So you have this kind of rim of outline of reticulin staining, and then this whole space in the middle with no reticulin staining. And again, to go over what we've looked at so far. So so this is just a table showing the difference between FNH, adenoma, and HCC. And the main things are morphology and reticulin staining, I'd say, for all of them, really. You get some changes in pseudoacinine, more common in HCCs. Mitotic figures are important, but that's morphology, both of those. Glutamine synthetase can be useful in identifying focal nodular hyperplasia. And I've just recapped the immuno that we're using. Okay, case 4 is a 56-year-old female with incidental liver lesion and no radiological evidence of cirrhosis. And I've just put the H&E in on this case. So this isn't actually my macro picture, I stole it. But here we have a well-circumscribed, partially encapsulated tan lesion. And on histo, we've got fatty lesion, hepatoid, pink cells, big vascular spaces. Cells are relatively benign looking, but they've got quite prominent nucleoli in areas. Some fat, some ballooning, possible Mallory material. But when you stain with HMB45, it's diffusely positive. Does anyone want to make a diagnosis? I think I've made it easy with the HMB45. Yes, exactly. Angiomyolipoma. Now, I find these extremely scary. It's not unusual for us to diagnose hepatocellular carcinomas on non-cirrhotic livers. It happens. But angiomyolipomas can mimic hepatocellular carcinoma, and you need to be thinking about them. So they're part of the Picoma family, more common in females. They do have a genetic mutation which is the same as that seen in tuberous sclerosis and can be associated with tuberous sclerosis. Their background, as we've mentioned, is non-cirrhotic, HMB45 and melanA positive, usually S100 SOX10 negative. Important for this is the fact that they can be glutamine synthetase positive. So if you're not thinking about it, you can walk straight into a big hole. As I mentioned, there's lots of variants described, but the most important for liver pathology is the epithelioid variant. If I saw this case without knowing any history, I would consider an HCC. It looks very hepatoid. It's got fat. It's got ballooning. The one earlier had something looking like Mallory material in it. To get nuclear, this is a more atypical epithelioid variant with nuclear atypia and prominent nucleoli. And as I said, glutamine synthetase diffusely positive. So got to be so careful. The other variant I'd probably say is be careful about is the inflammatory variant. Classically has these really big ganglion-like cells with dense inflammatory infiltrate, but the cells can look very atypical. You can get multi-nucleate kind of tumor giant cells. And it can look really horrid. It will come up with HMB45. Just make sure you don't misdiagnose metastatic melanoma or HCC, but it was a bit odd looking for an HCC. Okay, talking about mimics of hepatocellular carcinoma. Renal cell carcinoma. It's doesn't commonly met to the liver, but it can cause a lot of confusion when it does. Hopefully you should have some history, but sometimes you are not provided with it. And this would be a mimic of a clear cell renal cell carcinoma. Obviously the staining is very different. This won't be arginase and HepA1 or HSA positive, and it'll have a very different immunoprofile. But if you're just going on morphology, it will have the atypia, it will have these big these clear cell change, it will have loss of reticulin staining. So it can, and mitotic figures, so it can cause problems. Hepatoid adenocarcinoma is the other one. This can be positive for hepatocyte-specific markers or non-specific markers, I should say, and glypican-3. So again, be careful, because if you don't think about it and you go off down your HCC route, you can easily fall down again another big hole. So think about a Burr EP4 or a South or some epithelial marker. Okay, case 5 is a female, age 26. It was an incidental liver lesion. And given the age and the morphology, this is more of a spot, really. Lots of dense fibrosis, nodules of hepatoid cells, big cells with lots of abundant eosinophilic cytoplasm. This is a little bit pink on your screens, but prominent nucleoli, looks really horrid. I think there was a mitotic figure somewhere, but I can't see it now. And these pale bodies, or in my case, pink bodies. Does anyone want to make a diagnosis? So given the age and the atypia and the dense fibrosis, really, and the inclusions, which aren't specific but are classical. Here are the mitotic figures. I knew I had some somewhere. So this is a malignant lesion. And this is hepatocellular carcinoma, but it's fibrolamellar subtype. And that's a very different kettle of fish from a standard hepatocellular carcinoma. They occur in men and female, men and women equally. Very rare over the age of 50, and it's usually teenagers and young adults. They classically stain for CK7, CD8, macrophage marker CD68, and hepatocyte-specific antigen, arginase, HepA1. Over 90% of them are associated with specific gene fusion. despite the majority of cases having lymph node metastasis at presentation, they have a better prognosis than classical HCC. And these also do not arise on the background of cirrhosis. So young patients, non-cirrhotic background, this lamellar kind of fibrosis, prominent pink cytoplasm, big nucleoli, that's a fibrolamellar carcinoma. Well done, Heather, sorry, there was a delay and I didn't see your answer. Case number 6, 74-year-old male liver lesion. And here we can see macroscopically, you have the background liver and then you have this big spongy red lesion. And on microscopy, you can see this, you get an idea that there's a lesion here. It's very cellular, it's a bit blue in places, something going on here, maybe some area of necrosis, but it's very hard, it's very poorly defined. And if we go to the edge of the lesion, you'll see these big atypical cells, these bluer ones, but they're infiltrating in the sinusoids around the normal hepatocytes. And that's quite a classic pattern of spread for this tumour. Here we can see the nuclear atypia more, big nucleoli, an isonucleosis, quite a lot of cytoplasm still. Anyone want to make a diagnosis? The macroscopic description, I was saying how important macroscopy is. The macroscopic description is quite classical for these lesions. Okay, so yes, thank you, Heather. This is an angiosarcoma, and this is the ERG, which is a nuclear vascular marker. So this is an angiosarcoma. And you can kind of get the idea that maybe if you just saw this, you might mistake it for an HCC, big hepatoid-looking cells, maybe. I might be making that up. Other vascular tumours to watch out for, epithelioid hemangioendothelioma. This is the classic variant where you just have this almost scar with these cords of tumour cells infiltrating along. It can be very, very paucicellular, and I've seen colleagues call things just scarring, which have actually been hemangioendothelioma. So you do have to be very careful if you see a scar in a liver to examine it carefully. And then you have the alveolar, kind of pseudo-alveolar pattern. They're associated with different mutations. So today we have covered the importance of clinical history. We've discussed very briefly radiology because I'm not a radiologist. We've seen how macroscopy can help in your initial thoughts for your diagnosis. We've looked at the morphological features that can occur and the differences between benign and malignant, especially on the reticulin stain. We've seen how we can utilize glutamine synthetase in liver lesions, but know to be aware of angiomyolipomas, which are also glutamine synthetase positive. Looked at the differential stains in hepatocellular adenomas. We've had a look at HCCs and at metastatic tumours, but also other primary liver tumours which affect the liver, which aren't necessarily hepatocyte related. You will notice a large hole in my talk from cholangiocarcinomas, but this in itself is a massive talk and could easily take up 2 further talks. So I've left that out of this to make it simpler. I'm going to do a little bit, I didn't ask Richard actually if I could do this, but I'm going to do a little bit of plugging. The Royal College of Pathologists, I co-organise with Alan Cratchley the liver pathology bite-sized webinars. There's usually, I think, 5 or 6 a year. They're once every 2 months. It's an hour at lunchtime, so similar time to this, and they're free. So you only have to register with the college, don't pay anything, and you can attend them. Also, you can see the recordings from this year. We've just finished this year's set on the website, so you can get those for free, and they're done by experts in liver pathology in the UK. Okay, any questions? Or have I bamboozled you into silence? I can't hear you, Richard. You can put any questions in the chat while we're waiting for Richard, if it helps. I think Richard's having problems with sound. Does anyone have any other questions?
Now, can you hear me?
Oh, yeah, got you.
That's great. So thank you very much for that. Can you still hear me?
Yeah.
Great. Thank you very much for that fantastic talk. Are there any questions from the audience? Any questions? I can't. On a mobile, I can't see a chat function here, so it's difficult to see.
No,
Ava,
I'm
are there any questions in the chat?
No, there are no questions.
Okay. Well, I've got a question. I don't know, Ali, whether you mentioned sarcomatoid mesotheliomas. Can you get those in the liver?
I have not seen them. No.
Okay.
Okay. Sorry, carry on.
I only ask of interest because a post-mortem case I had recently was query sarcomatoid mesothelioma with the liver, or query cholangiocarcinoma. So obviously, if you've not seen them, they're pretty rare. So that's my answer, I guess.
The cholangiocarcinomas can have. I'm seeing so many now because we're kind of referral centre, and they can have such bizarre morphology.
Okay. Okay.
So if
you see something really bizarre in the liver, always consider a cholangio. Yeah,
I mean, I didn't, as I said to them before you joined, I haven't touched on cholangiocarcinomas because that's probably one or two further lectures. But yeah, cholangiocarcinomas, they can look quite bizarre and quite different. It's a wide spectrum of morphology, put it that way.
Well, we're very grateful to have you back then, but I have the timetable full till the end of the academic year, but I'm already looking for people for September, so I might ask you to come back at the start of the next academic year to do cholangiocarcinomas, if that's okay. And thank you for putting the Royal College plug in. I think that's going to be very useful for people as well. We don't want this teaching to be exclusive. We want to be able to signpost to other things as well.
Well, it's free and it's good, so.
Yeah, I'm sure it is. I mean, that was an excellent lecture. As I say, I'm on a site visit at the moment, but I have been able to see some of it along the way. And I think some of the algorithms that you've presented and the tables are going to be really useful. And Ava, I assume that with this new platform, the recording will still go out to the delegates. Is that correct?
Yes.
That's great. That's great. I think this will be a really useful resource for everyone. Thank you, Ali.
Thanks.
If there are no further questions, in the interest of Ali's very busy day, I think we can draw it to a close, unless there are any further questions anyone wants to ask. No? So I've also another plug for additional teaching. Next week, actually so I will be doing the normal HemePath teaching at the normal time on Wednesday next week, again on this platform. And next Thursday, the northwest of the UK general kind of educational EQA scheme will be having its 6-monthly meeting, and all the members of this can attend, and the attendance will be by logging into this same webinar link, and then I will present the educational EQA through that link. So that will be on Tuesday afternoon UK time. I'll send an email to Ava and she can send out the details to everyone on the circulation list. So that'll be an additional education session next Tuesday afternoon UK time. So 1 to 2 hours ahead in most African countries and further ahead out into Asia. So as many of you as wish can attend that as well. It covers all branches of histopathology, and it's a general scheme. So the level isn't pitched at expert level, so it's very good educational. And we also have a talk on GI from Neil Shepherd, who's a very eminent UK GI pathologist. So that will be a very good lecture. I think that's it for today, unless, Ava, I've forgotten to mention anything, or there's anything to say in addition.
No, I think that's everything.
How did you find this new platform, Ali and Ava? Was it okay?
Yeah, I think so.
That's great. I found, I think it might be a little harder on a mobile, but it'll be fine on any other platform. I'm sure I'll get to grips with it. It presents everything very nicely to the audience. And Ava, you'll give me the attendance numbers in due course, and I can convey those to Ali as well.
Yeah.
Okay. Well, thank you very much for your time. I know that I always feel that my thanks are inadequate, because without the external speakers like yourself, Ali, there would be no program. It is all down to you and your colleagues. And your lecture today was really beautifully presented. There was information on IHC, and I know that you'd mentioned how many have access to IHC, but it wasn't exclusively IHC. And I think that some of those algorithms were really good to point people down different diagnostic pathways. So thank you very much.